I want to briefly talk about damage control orthopedics. This could be another talk as well, but I think it's important for us going down there to understand the concept in order to plan and let the patient know what the plan will be for their injury. But the concept of delaying definitive treatment until their physiology is improved is what damage control orthopedics is all about. Kind of replace the previous thought and philosophy of early total care where the patients are too sick not to operate, so you operate on them. Well, now we know that that's not exactly correct, because until their physiology is improved and they're not as vulnerable from a hemodynamics and just medical perspective, we can stabilize them in other ways instead of taking them, and on the next slide we'll talk about where we could actually traumatize them even more with a second hit phenomenon. The timing of this is still controversial, but the actual philosophy of this is pretty well entertained at this point. There are multiple parameters that throw a patient into the need for this. Injury severity scales that are high, patients with altered mental status, head injuries, bilateral femurs. But we can stabilize these patients for definitive management with external fixation, skeletal traction. These patients may be upstairs in an ICU for 5+ days before we get to do something, or we may need to change our plan and do something at the bedside in order to temporize them before they can actually go to the OR. Early appropriate care is great for those that it's appropriate for, and that's obviously our goal in isolated, kind of the lower injury type traumas with just isolated orthopedic injuries. We're guided by this laboratory data that's well. The trauma team doesn't even want to be on board. They're so great, and that's fine. These patients can typically go within 36 hours. We know that's the optimal situation for those that's actually appropriate for, with the goal of decreasing complications, getting them out of bed, and getting them out of the hospital as soon as we can. And why all the talk about the damage control? Well, these patients are at high risk from multi-system organ failure, acute respiratory distress. These are the sickest of the sick of our trauma patients with extremely high incidence of mortality. We know that this physiology is a response to the trauma, very inflammatory in nature, but we need to always be aware that when we're trying to differentiate this early care versus damage control, that this is what we're concerned about with making them wait.